practitioner. This is week 4 of our Learning Collaborative 201, focused on advanced payment models, or alternative payment models. And this week we will focus on clinically integrated networks, opportunities and barriers for rural providers. Again, we have the external SharePoint page where we will post the webinar recordings for those who are not able to attend live. We have 2 meetings after this one. Next week I will be out of the office, so Tracy will be facilitating the intro section. And just a reminder, as a completion of the Learning Collaborative, we will be asking each participating Flex program to complete an action plan based on the findings or suggestions of the Learning Collaborative, some activity or activities that you can incorporate into your Flex program related to or based on the Learning Collaborative. And more information or details will come on that. We also have a template for the action plan for you guys, but we'll get more on that later. Just wanted to make sure we introduce that topic. If we don't have any questions or any other announcements, Shannon, I'll let you take it away.
Thank you, Caleb, and good afternoon, everyone. As Caleb said, this is the Learning Collaborative 201, Week 4. And I would like to take the opportunity to say thank you again to the National Rural Health Resource Center for allowing us to have this webinar series and provide you 6 weeks worth of information connected to their 5 core values. The context, as a reminder, if some of you have participated in previous webinars of this series, we have the intention of going over the components of healthcare transformation, creating an understanding for you. Also touch on how transformation affects critical access hospitals and rural health clinics. And somewhere along the way, hopefully you're able to pick up some tools and resources to help providers engage in transformation. Our series is, those 6 were obviously on week 4, but just as a reminder also, week 1 was focused specifically on who is leading the transformation, which is the Centers for Medicare and Medicaid. We talked about their payment and delivery reform. Week 2 was the paradigm shift, focusing on a bigger picture, including Medicare, Medicaid, and commercial payers, as well as demographic changes and the effects of those on rural health. Last week, we did a deep dive into accountable care organizations and also touched on pay-for-value programs, again, looking at opportunities and barriers for rural providers. This week, we'll be talking about clinically integrated networks, and I look forward to sharing with you some thoughts on that. We'll follow up and continue to build on the learning in week 5, specifically focusing on the charity in small numbers, or how to be successful in a low-volume provider. And then week 6, of course, we'll wrap it up with a big picture and how we can somehow paint with results that makes it valuable to payers. So today, we're going to look at the definition of clinically integrated networks. We'll also dig in a little bit on components, and then we will spend some time on the value and the obstacles of participating in clinically integrated networks. So let's just dive in. Actually, clinical integration has been around for a while. I do remember working with it in the mid-90s, and it really was a little bit different in focus. It really came out of systems, connecting with systems, really looking at being able to negotiate for a better rate, among other things. The FTC, or the Federal Trade Commission, really has now legally defined clinical integration. We'll talk a little bit about that. And it's interesting to note that it's almost been 40 years since that early talk of clinical integration, and providers, some could actually claim that they've been doing integration for decades. So the American Medical Association actually defines it as the means to facilitate the coordination of patient care across conditions, providers, settings, and time in order to achieve care that is safely and timely and effective, efficient, equitable, and patient-focused. Now, it's interesting to note that a lot of the meaning of this definition really is tied very much to what we've talked about in ACOs and other alternative payment models, as well as just the discussion on what's happening on the commercial side. So clinical integration obviously is a part of the payment and delivery reform. I also have made an effort to put a couple of places in red to sort of tie that together for you on the triple aim, and we'll see a few other places in this presentation. So clinical integration actually happens in a network, hence the term clinically integrated network. And a lot of times those networks are disparate systems, separate tax ID numbers. Similar goals with other entities align with accountable care organizations, patient-centered medical homes, physician hospital organizations, and independent practice associations. Now, there are some differences in those organizations and what they do as specific of a clinically integrated network. An ACO, as you know, if you joined us last week, is that it focuses on care improvement for an entire patient population through various healthcare delivery systems, while patient-centered medical homes focus on care improvement for primary care services. An independent physician organization as well as a physician hospital organization really are focused on financial integration and doing that in risk sharing. So any one of these could interchange with the other, and if you notice, they all sort of serve the purpose of the definition of clinical integration as well as alternative payment model. So I haven't really said clearly what it is or isn't, so I'm going to take another swing at it for you. And clinical integration has many definitions, but it's not necessarily literal or specific. It does not require a closed system, which people might actually connect that with, where it's one hospital, one healthcare system, or organization that monitors and influences the patient care within that system. So it's not a closed system. It's not firm. Counter to that, clinical integration is a continuous process of alignment across the care continuum. So the continuum can be defined, and we'll look at some of the types of integration in just a few minutes, but it supports the triple aim of healthcare, which is better health, better care, better health, better care, lower cost. So again, interesting that clinically integrated networks to some degree align with what we've talked about in the alternative payment model. It's important to note, however, that clinically integrated networks are not a payment model. They are a legal structure. They're a great vehicle to combine providers to perform collectively in a payment model. So just note that they are a legal structure, a legal vehicle, but they are not a payment model. This depicts the difference of horizontal and vertical integration, and clinically integrated networks basically can have both and sometimes do have both. An ACO is a perfect way of looking at vertical integration, particularly in the collaborative ACOs that we've seen where rurals participated across the country. And that included primary care providers as well as hospitals, and then perhaps even ancillary services that participated in the care of the patient population that's included in the ACO. You can be 100% vertically integrated, or you could just be horizontally integrated, or some sort of mix. But that's the importance of knowing what your goal is and having clinical integration. So the components of a clinically integrated network are very similar also with the ACOs. You may recognize this. The first, of course, is legal options. If you're forming a tax ID number, an entity with a new tax ID number, you really need to figure out what the operations is going to be, what the actual organizational structure is going to be. We did see across the country in some ACOs in the collaborative side actually use an existing TIN where when there's a mix of disparate systems that weren't specifically or geographically focused, or there were unknown participants, it was a new tax ID number where each was equal in the participation under that. So you need to really have a good understanding of what the best approach is for what you're trying to achieve in a clinically integrated network. Next is physician leadership, and obviously you need physicians somewhere at the helm because we're talking, of course, about clinical integration. Sometimes it would be helpful in connecting an ACO inside of a clinically integrated network that you do have physicians at the leadership, because that makes a better outcome for that particular model that you're forming it for. It's not always required, but certainly you need someone that can be a champion of the ideas throughout the providers participating and know that they all have a good voice in their endeavors of integrating across the spectrum. The next step is to consider what is the participation criteria. I think this means that you need to have really good expectations of what a provider would do or an entity would do in joining the clinically integrated network, but also whoever's participating should have a good idea and understanding of what they're getting into. So you need to have really good clarity. Will they get paid? How will the split be? You need to have a good understanding of the flow back and forth between participation and ownership in a clinically integrated network. Of course, performance improvement is really tied to a lot of payment models, but what's noted here that's really important is that performance improvement is really key to being legal in clinically integrating across tax ID numbers. So having a very solid performance improvement model, having a baseline, and then understanding what the performance metrics will be and are they actually realistic for the participants. That's also part of baking that into your participation criteria. Can the providers actually achieve what the intention is through this performance improvement? Next, of course, is information technology, and there's a lot of interesting opportunities as well as problems in considering information technology. First and foremost is separate tax ID numbers probably have separate technologies that are or are not interoperable. So it's important to know that your plan includes what data you're going to use, how you're going to use it, who's going to have access to that, and then is that supportable across the spectrum and with their connection of their technology. Contracting options is important if you're creating a CIN specific to engaging with commercial payer value-based payment programs. So you would want to know in advance, if that's what you're going to do, have the ability to have that in the participation criteria, have some baselines of what the varying participation criteria would be based on what contract you would be engaging in. So again, it would help to be somewhat broad if you are intending to do something that's more than one engagement in the payment and delivery reform. And then, of course, you always know it's all about the dollar. You have to understand and be able to portray with transparency the flow of funds. Each provider would want to know what actions they have to do, whether those actions align with what their opportunity and return on investment is. So that's a lot of planning in advance of preparing for a really comprehensive clinically integrated network. So we talked, I mentioned before about the Federal Trade Commission, and even though it's not what we would define as a firm definition of clinical integration, the FTC has a set of parameters, and I won't go into them. It is very legal, but the short end of the story is that it really addresses the issue of staying within guidelines against fraud, abuse, and anti-competition. So it follows the statutes of the START law, or physician self-referral, the anti-kickback statute, civil monetary penalties, and, of course, federal and state antitrust laws. I've always said that one thing that's really important and remarkable about an ACO is that it gives you two very important gifts. ACOs actually give you an FTC waiver for START and antitrust. Because you are integrating across a group of providers, you have claims data, and you are accountable collectively for a pool that passes the sniff test for FTC's clinical integration requirements. So what I would say is that probably the most important thing about having FTC proper guidelines within your clinically integrated network is that it needs to be very, very clear and very documented in that it is the goal of improving care and not only to bargain for better rates. That's considered price fixing and anti-competition, and it's a per se violation to do those things without being able to demonstrate that your full intention on taking on the risk was to improve care. So added to that, the other legal consideration is that it really is very intensive and facts in regard to making sure that you are within those compliance guidelines. So having an attorney that does the review of the documents is really, really important, because you're moving in a place that has a trigger, a very sharp trigger of moving from black to white on the appropriate legalness of doing integration across competing tax ID numbers. So I believe there's lots of opportunities of participating in a clinically integrated network. We'll counter this, obviously, with the barriers or obstacles, and it's interesting that what is a barrier could also be an opportunity, so we'll share that in a few minutes. Several things overlap with what we've talked about as well. Payment reform, delivery reform. I talked earlier about in one of the previous webinars about virtual integration, and I think that you'll see as we walk through each one of these how they overlap, so how this can actually serve you to be successful in any one of those. The first and foremost is it creates a very firm administrative infrastructure to share information and generate revenue collectively. Now, second to that, it allows for virtual integration and collaboration. So sometimes it's okay to do collaboration with competitors, but having the integration across patients sometimes can get very complicated and somewhat legal. So having the platform, again, to give some comfort level for the people who want to collaborate through types of integration, even remotely, virtually, that may or may not be in the same geographic region or sharing patients, could collaborate within this framework. Again, an example is those large collaborative ACOs that we see Caravan doing. Those are virtual. They're not necessarily specific to a region or contiguous group of providers, and it's definitely a defined group of collaboration. But the platform that was created under the ACO, very similar and aligned with clinically integrated networks, gave an opportunity for that to happen. The platform gave it to happen, gave it the chance to happen. The other thing is that by being able to virtually integrate, you have the opportunity to have enough volume to engage in the payment methodology. Again, speak to the ACO, ACOs required that there was a minimum of 5,000 Medicare beneficiaries attributed. Medicare, or actually not Medicare, but commercial payers really like to see 50,000 attributed lives before they do really group negotiations. So how would a rural provider have the ability to do that? Through virtual integration and collaboration in a legal infrastructure such as a CIN. So it gives the opportunity to have volume and of data and of lives to create empirical evidence to act as as a stronger entity. And that sort of leans to the next statement, which is a way to maintain financial autonomy but act with enterprise strength. We've seen in the country in the last couple of years lots of physician practices being bought up by hospitals, and the intention was to create that larger amount of strength in the community. And during that time, that was acceptable by the providers because they were having a hard time really engaging in enterprise solutions, the ability, again, to have enterprise strength. So if you don't want to be bought or you don't want to buy somebody as a rural provider or a rural provider engaging with another entity, working with a clinically integrated network gives you the ability to work collectively as an enterprise under one tax ID number, but still maintain your financial autonomy and have financial independence in your own controls of your own tax ID number. I think that's a really strong point about the clinically integrated network. It does, of course, as I said before, provide a vehicle to successfully engage in value-based payment programs and the alternative payment models. It's also a vehicle to share in the cost of infrastructure for transformation. We all know that transformation, much like described in this components of the CIN, requires new technology, maybe some new delivery components, certainly some different views and approaches with staff, including physicians. So having a way to be able to build that infrastructure and do that collectively and the sharing of the cost of that with other members gives you an opportunity to be much more successful with a sooner return on investment. A couple of other sidebar opportunities is that once physicians buy into this and understand the value of it, it gives them the opportunity with the information and the legal protections to ensure the delivery of optimal, efficient care. They have the ability to have the data and the ability to have the conversations with physicians, other physicians that might be competing or outside their tax ID numbers about information that they could not have done so before. So it really broadens the opportunity for delivery reform, and of course that ties into payment reform. Finally, and this just ties to what I said, it's a strong foundation for moving forward and towards new payment models that reward providers for high quality and high value care. So you can get paid more, you can collaborate, you can act as an enterprise, you can engage in sharing costs and get better return on investment by participating in a clinically integrated network. I want to touch just briefly about ACOs versus CIN. I said in a couple of slides before, but just to note, an ACO is a type of alternative payment model that gives incentive payments on high quality and cost-efficient care. It is an alternative payment model, and I would say a form of a CIN. It is a type of a CIN, specifically in the way that the Medicare Shared Savings Program did. Does not mean that a CIN has to be a payment model, but the ACOs offered under the MSSP program and delivered by what we saw under Caravan really created a new tax ID number that allowed legal protections, so it operated just like a CIN. Last week, we also touched on what the components were for alternative payment model, and I won't belabor these. We talked about them a bit last week, but what's interesting to note is each and every one of these ties into the definition of clinical integration and can be achieved under clinical integration. So it aligns very well with alternative payment models to be in a CIN. The same holds true for virtually integrated delivery systems. I shared this, I believe, in week 1, maybe in week 2, but this comes from a book called The Managed Care Handbook by Peter Kongsfeld in 1997, really talking about a model or a way in which they can see transformation. I see rural participation in clinically integrated networks as virtually integrated delivery systems because they don't necessarily work in the same town. They don't necessarily, in collaboration, share the same patients, but they share the same barriers and they share the same methodologies for delivery. So in that way, they look like a horizontal virtual integrated delivery system. So now let's briefly talk about the obstacles. There are several barriers for rural providers, and you might recognize them as the same things that I said in the opportunities. So let's just dive into these 5: legal, collaboration, volume, infrastructure costs, and not being a payment model. So the legal obstacles focus quite a bit on the concern of the FTC compliance. That one is a big one, and it is very specific, and it is very limiting. So the first legal obstacle is that you really have to meet that requirement. The second one is that building the compensation arrangements. We did see those in some alternative payment models where you wanted to be able to tie those new payment models, or not necessarily payment models, but physician and employment contracts to outcome-based financial incentives, and those also need to be within compliance of the FTC rules. If you are engaging in joint contract negotiations, which I'm very familiar with, I actually work with a rural network that does group payer contracting. And if you are joint negotiating with competing providers, you have to be very, very close to and within the antitrust FTC guidelines. So those are barriers in and of themselves, but as rural providers, having volume, having the ability to engage in the cost of these could be an even bigger barrier. And then the last is that, and I mentioned this before, but these are very interesting compliance regulations, and they look to the effect and not necessarily the intent when they're applying the compliance of these rules. And so paying close attention to the facts of the implementation and the outcome on a regular basis is really critical to stay within those legal guidelines. I mentioned before, collaboration is an opportunity, but it is and sometimes a barrier. Rural people in general are great at collaborating. If a provider community in one town is only 30 miles away from another, the perspective could be that it's competition, that they're losing patients from one place to another. And I think that there's certainly a lot of argument that's not necessarily the case. And I myself have done that for 20 years with up to 13 communities collaborating and payer contracting that was not in a competing manner. So it's an idea, a new way of thinking that you need to get over in order to be able to be comfortable in collaborating. And we saw this even in the implementation, again, of the ACOs, where rural providers at first thought, well, I don't have all the information, I don't have enough patients, so maybe they're going to want to take away my patients. And having the ability to understand the participation agreement, the intention, how the data is shared, how they act upon the data, and the outcome, and transparency really reduce the collaboration obstacle of participating in a collaborative ACO. So it requires due diligence and trust to create that alignment. And then the other obstacle is finding some balance within the governance and leadership and being able to make sure that the transparency of those two, both governance and leadership, are shared consistently so that the trust is maintained across the whole collective. So that makes it a little hard to do. Infrastructure costs, you've probably guessed that I've already spoke about in infrastructure, but forming an entity is not that expensive, but having all the documents in place to meet the legal requirements could be quite a bit of a cost. Determining the technology that meets the collaboration not just tying all of them together, which is a feat in and of itself, but then having a platform that allows everyone to be able to use it in the way they want, that they trust it, that they have the ability to have input and output that is fair and equitable and with trust. Analytics is a new department, a new effort from rural providers. So analytics in the collective is one cost, but then having it disseminated across multiple sites would extend that cost a little bit. So the price of analytics would be a cost that would probably only be achieved by sharing. So I actually say that that's an opportunity in the CIN as well as the cost of it. Then a lot of times you see clinically integrated networks started by hospital systems because they already have existing infrastructure. They already have existing talent within their system to be able to do that. If you're not dealing or creating a CIN with that, you would have the cost of the administration and management of the CIN in itself. It's like a separate department at the minimum and a whole nother entity under a tax ID at the most. So having the ability to have finance, governance, and leadership all within that tax ID number that is trusted could be somewhat costly. And then we talked about legal. I won't belabor that. You've got to have somebody up front and then somebody watching pretty regular. Building the network, an early cost. Managing the network would probably follow. You wouldn't necessarily always be building the network, but getting people on board, getting them to sign the contract, agreeing for them to maintain those contracts. If, in fact, the purpose is to negotiate commercial payer contracts, then you actually have a payer contracting department within the CIN, or you would need one, because that's quite a bit of management of different contracts that would be then from tax ID down to independent tax IDs to participation. And payment models, the delivery, the maintenance, and the implementation of the cost and quality measurements to participate in the payment models could end up being another department as well. Not necessarily if they're small, strong providers, rural communities tied together that have those strong quality departments that already are doing prevention and wellness, population health care coordination, and being able to report the cost and quality measurements. It might not be as difficult as starting from scratch with no one participating in that. But again, someone collectively needs to be watching that everyone is aligned and participating in the cost and quality measurement. So is the CIN the rural option? And I won't necessarily say that it is or it isn't, but we will apply this thought to the next two webinars, those under the tyranny of small numbers and the big picture results matter. This is important to note on both of these, that there needs to be considered a rural option that engages them in this payment and transformation. So hopefully this may not be the answer, but raises questions for all of you to help find the answer. And the last thing I'm going to say, by the way, this is a bit of a short webinar, and maybe there could be questions if anyone has any. But the important note here is that throughout every webinar, and I probably told you on the last one, we're going to see this slide every single webinar, because if we do nothing, if we do nothing, we must share that the data reflects the story of high quality and low cost in order to be engaged in future payment models. With that, I'm going to pause and see if anyone has questions specifically about CINs. I managed one. It was too much before our time for us to be fully clinically integrated, so it was on the platform of an integrated delivery system, but we were not large enough to be able to get to the point of actually caring for a population. It was before our time to do that. but I'll be happy to share any answers to any questions you may have about the formation of that organization and the activities that we did. They still do have a payer contracting arm that is legal and appropriate even without clinical integration. So with that, if you have any questions, you can do *2 and ask me, or feel free to type in the chat box.
As we wait for some questions to come in, can you talk a little bit, Shannon, about the difference between a clinically integrated network and what I think of just in care coordination? Is it just the legal paperwork and creation of separate entities with memorandums of understanding and the opportunities to connect to the ACO? Or is it, does it have to be that?
Yeah, so when you're talking about, clinical, care coordination, are you referring to one entity providing the service for another entity of doing, like providing a nurse and doing the billable service?
Not necessarily. So in my head, I'm thinking of, a small town where maybe the clinic is not owned by the hospital and there's a skilled nursing facility there in town, and Mary goes from hospital to clinic to skilled nursing facility kind of regularly, and we can, we need to share appointment schedules and updates and visit information on Mary's last visit and trip to the hospital and follow-up appointments being scheduled and medication reconciliation back and forth between those three entities, and really helping coordinate Mary's care. That's what I'm thinking of when I'm thinking of care coordination.
Right. So care coordination in and of itself, and the purpose of being able to work with a patient from one site of care to another site of care isn't necessarily sharing any financial information, and it's not necessarily billing under one tax ID and then splitting the revenue of that. So I think those two things make that be, care coordination in and of itself is a new, of course, CPT code that allows that care of the continuum to some degree, but the degree that we've seen care coordination in the ACOs really differentiated itself when the ACO received claims data of competing providers. So you can actually see financial information of what was spent in this office versus that office. That is where the legal line sort of is drawn for the value of a clinically integrated network in the form that I just presented it. Does that help?
Okay. Yeah, that makes sense.
Mm-hmm. Yeah, I think the trick there between clinical integration from the creating a network is several different tax ID numbers operating as an enterprise of one tax ID number external to someone else. And the way you described, they're collaborating with each other, but they're not trying to sell that collaboration collectively to the commercial payer or even Medicare. They're just working with each other.
Right, yeah, working with each other as opposed to billing with each other.
Right.
Okay, yeah, cool, thank you.
Yeah.
And Edwards has a question, or just a comment. Thanks for helping us better understand a complex topic. I agree, Jen, thank you.
Sure, it is mushy. It's not really clear, and I struggled with trying to draw a picture, but I really needed a hologram, and I didn't know how to do that and get it across. So you got a two-dimensional one there. Any other questions or thoughts?
Yeah, what other questions do we have? *2 will unmute your line.
With that, I would like to say, go ahead.
I'm not sure how to formulate this question, but I guess what I'm sort of wondering is, Okay, I understand clinically integrated networks are basically a bunch of individuals that are sort of forming together for a network for a single tax ID to provide sort of coordinated, a coordinated level of care, and not, and it could be services if it's vertically as opposed to horizontally integrated. And then, and I'm sorry, I'm just sort of thinking, so how does the primary, or that, how does the patient-centered medical home, I know that they're a single taxpayer entity, but they also are sort of doing something similar, although,
Yeah,
again,
yeah, it's an actual official designation. So, you know, patient-centered medical home has a checklist of what you can do, and it's defined on quality. So it's a little less squishy than a SIN, but it doesn't necessarily have the intention always. Some people may use patient-centered medical homes in the shell of what something like a CIN would be. For the purpose of both being high quality by acknowledgement of the designation of PCMH, but then they may use the vehicle of the CIN in order to be able to negotiate with a payer. So, okay. A PCMH, at first I thought PCMH was a payment model, and it's really not. It's a designation that sometimes payers are willing to pay for because you made that designation, and that designation equals cost and quality, but it's not necessarily a payment methodology. It's a designation.
Okay.
Does that help?
Yeah, that helps. Yeah, that helps get it a little less squishy. It's still a little, okay. But yeah, that helps.
Yeah, I see the opportunity. So years ago, there was a group of rural hospitals in Texas that really had a couple of things they wanted to achieve that they didn't have the opportunity to do individually. And really, they were created on the onset of Columbia HCA coming into the marketplace and making them worried about the packaging of physicians and hospitals and being able to, you know, dominate the market. So it was really a market move for them to create this collaboration. And under that opportunity, they were able to do several things collectively that they would not have been able to do as an independent, even health system, which we might have been made up of a critical access hospital and a couple of rural health clinics. We see a lot of activity in rural health networks across the country that do a lot of things in shared services, but we know they're more than a group purchasing organization. They're sharing services, and in this time that we see so much creativity, you know, I guess another interesting way to look at a clinically integrated model might be CVS and Aetna, or United and whoever they're building as their own clinic. You're seeing a payer and a provider come together to deliver service and get paid. So it's payment and delivery reform in a twisted way of participants in a collective payment methodology. That sounded just as squishy, didn't it?
It helps.
Another way to think about it. Yeah. So I see that rural health networks have the opportunity to engage in the opportunities that's brought by clinically integrated networks to be more successful in whatever payment methodologies have requirements bigger than their own. And what I would suggest in that regard would be information technology platforms for population health, and I would also see analytics having the ability, and then volume, which I'm going to talk about tyranny of small numbers next week, but having the ability to have enough volume that becomes significant to a payer that you're going to be more than a blip on the screen is really, really valuable in this day and time. As we see the erosion of the government payments, Medicare, Medicaid, moving to Medicaid managed care and Medicare Advantage, which makes them fall off the cost report, into the commercial world. And the commercial world says fee schedules are flat. The only way to increase payment is through value-based payment programs. So how can rural providers do that? How can they actually be able to do that without having enough volume to have empirical data and meet the attribution requirements and have the infrastructure? So my reason for adding this to transformation around alternative payment models is this vehicle of clinically integrated networks, which is a hot buzz and a lot more highly recognized than it was 20 years ago, is a very valuable opportunity. So I do see, Lynette says, clinical integration is a robust care coordination effort. Yes, it is. And it's back to that slide that I described, which is continuous improvement. I believe I had that in here. And that form of clinical integration, it is, but it can also be a legal vehicle to provide the opportunity to do greater clinical integration than you could with disparate systems. Does that make sense? Hopefully, Lynette, that makes sense with you. Let me move that back to across the continuum.
Yes, it does. I couldn't unmute my phone. I had it on mute. So you did a great presentation. I really like how you summarized everything in easy terms to understand. So
well,
thank you for that.
Yeah, I surely try. It's not easy, as you could probably tell, but it's important. I think it's really, really important. And I love that it's seen as a care coordination effort, but it's the part of care coordination that's engaging in payment reform and delivery reform.
Absolutely, which is much needed.
Much needed. And the way to do that, we still have to have volume and infrastructure. So how can we do that without legal structure that allows us to do that? Any other thoughts or questions? Hopefully I haven't confused more. I guess with that, Caleb, we'll give them about 12 minutes of their day.
Yeah, sounds good. Well, thank you everyone for taking the time to participate in the live webinar. If you need to get to the recording, Andy will get it posted to the external SharePoint page, and an email notification will be coming just as soon as possible. If you have any questions in the meantime, please don't hesitate to reach out to myself or to Andy or Shannon. My email address is csyme@ruralcenter.org, and Shannon's, I believe, is on the last slide here.
Yeah.
If I can get there.
There you go.
Yeah. Otherwise, please don't hesitate to reach out. Thanks, guys. Thanks for taking the time. Thank you, Shannon.
You're welcome. Thank you, everyone.
Thank you.
This conference is no longer being recorded.
Yes, Lynette, you are.